parent is kind of pushing back. They're not wanting to get that diagnosis. And I often say to them, you know, we don't need a diagnosis to kind of do certain things, right? There are certain things that we can set up for kids on the spectrum or exhibiting symptoms like on the spectrum that can help that child be more functional. And so even though they get this diagnosis, they're still going to need primary care services. They're still going to need child checks. They're still going to get the flu and things like that. So I wanted to talk a little bit about kind of some of the comorbidities and then, you know, setting up a practice that's more friendly toward this population. And so we see a lot of intellectual disability. There's a 41% prevalence with kids being on the spectrum. We've talked about that seizure disorders are often common with autism spectrum disorders, as well as gut issues. So you want to watch for things like diarrhea and constipation and all the symptomology that goes along with that. We see maladaptive behaviors such as self-injurious behavior and aggressive behavior. Sleep disorders are very common. As the child ages, we can see other kind of psychiatric disorders pop up, such as depression and anxiety, so we want to be mindful of that. We also see motor disruptions as well. Another common kind of first symptom of autism is toe walking. So kind of they're up on their toes and their heels aren't touching. Another kind of common physical development out of autism is the V-sit. So I don't know if I can do this where you can all see me, or if I can get up after I do it. So, but kind of this sitting where your pelvis is out and your legs are behind you. Can everybody see that? So that V-sit, which can be bad on the knees and the hips, as I just found. The things I do to teach you people. No, I'm just kidding. So watching for things like that. This is again from the CDC website of behaviors that you might see in your patients who have this diagnosis. We're also remembering that pain with kids on the spectrum can be really hard to tease out, especially if you have a communication disorder. Some of these kids have really high tolerances to pain. It just registers differently for them. And so we have seen kids on the spectrum that, you know, have broken toe or broken bones in their feet and things like that, and they just kept going. And so again, being mindful of the things that we watch for when kids get broken bones, such as child abuse and things like that, but also being aware that pain tolerances can be different for this population. So our treatment goals, as far as the autism symptomology, are to improve social functioning, especially play skills. For kids on the spectrum, work is often play and play is often work. So if we think about how spontaneous play is and how fun that can be a nightmare for kids who are on the spectrum. We want to, of course, improve their communication skills. We'll talk about what that looks like. Improve their adaptive functioning, so increasing flexibility, things like that. Decreasing negative behaviors and promoting academic functioning and cognition. So our treatment modalities are both communicative, such as educational and behavioral interventions. They can be pharmacologic, as well as alternative therapies such as chiropractic care, dietary care, and things like this. So one of the families that I got introduced to when I was working with this population was Equine Therapy. And so they were actually twins who were both diagnosed with autism. One was a little bit higher functioning than the other. And once a week on Saturday, they would go to Coffee Creek, which is in the kind of the Deer Creek area, and do horseback riding. They were pretty young at the time, between 3 and 4 years of age, but it was pretty incredible the leaps that we saw after they would be with these horses. There was riding involved, brushing the horses, talking with the horses, things like this. I actually got to go observe one morning, and it was so cool to see, and we ended up going to Target afterwards with the family, and they were pointing and talking like I had not seen them do before. Again, purely anecdotal, right? But those little kind of rays of hope for families can be really important throughout this process. And it certainly wasn't doing any harm, right? So it was really cool to see these children interact with these animals and the progress that they made. I told you my Stratera story with Bo, and then we'll talk about more of these behavioral interventions. So back when I was working with this population in the early 2000s, ABA, or Applied Behavioral Analysis, was very, very new. And in fact, there weren't a lot of therapists in Oklahoma. In fact, there were none who were actually trained here in the area. That has since changed. There are actually ABA certifications, there are training programs here in Oklahoma, and that's very exciting. So I do need to preface this by saying I am not ABA certified, because that wasn't a thing when I was doing this. The family that recruited me actually hired a consulting firm out of Florida called Reaching Potentials, and they flew a consultant here to Oklahoma every 3 to 4 months to assess the child on where their skills were, or on where his skills were, develop a program specific for him, and then we would videotape sessions and send them back to Florida for review, and then we would do that every 3 months. At the time, none of this was covered by insurance. Insurance has gotten a little bit better, but it won't pay for the intensity that ABA requires. So an ABA program is typically 40 hours a week, so it is kind of a full-time job for these kids to teach them everything there is to know, from academic skills, reading, writing, to communication, to even just how to imitate and how to play. It is one of the more evidence-based practices out there. Some of the other behavioral interventions that you'll come across if you spend any time in this realm is Floor Time by Stanley Greenspan, who is out of California, and Teach. You might also run into the PECS communication system, which is a card system where children would have a kind of binder full of pictures of things that they might request. and that they would hand that over in exchange for the item that they needed. They're doing more of that with technology now, so you'll see kids with iPads and communicating that way. So ABA is based on kind of that social learning theory. In the beginning, it included both reward and punishment, but as ABA evolved, it became more reward-centered. As I said, generally it's a 40-hour-a-week program. The child that I initially started working with, I was seeing him twice a day for about 2 hours a day, so I was with him, 25 hours a week. And then his mother was doing ABA sessions as well as his grandmother. Now, truth be told, Grandma's sessions were a little less stringent than Mom and I, but that's okay. In fact, ABA is really quite difficult for families to do sometimes because it requires such diligence, and it always requires the child to have some kind of response, which often means children are crying and hiding under tables, which is a little difficult for moms and dads to cope with sometimes. And grandmas, right? In fact, in all the families that I worked with, the first family that I worked with, this mom was the only mom who was able to actually do it. And she was pretty committed to helping her son. And not that the other moms and dads that I worked with weren't, but it was a different kind of level of commitment that she showed. So again, it uses positive reinforcement to increase positive behaviors. So we would assess the child using the ABLES, which again gave us information about where they were as far as imitation skills, where they were on expressive as well as receptive language, where they were with math and reading. And we would build programs, specific discrete trials, to then build on those skills. So for example, if you want to teach anybody anything, imitation is a huge part of that. Children, typically, are natural at imitating other people, right? Good, bad, or ugly. That's something that we actually need to teach children on the spectrum. So before we can even start, we have to teach skills like do this, okay? So if I can have a volunteer, would you help me? Sure. Okay, if you will kind of scoot over, I don't want to hit your computer. All right, so what is your name?
Kathleen.
Kathleen. So if Kathleen is one of my students, I'm going to be sitting in front of her at a very small table, and we're going to start with something as simple as do this. Now, Kathleen is on the spectrum, so she doesn't know how to do this, so I have to show her. So the first thing I'm going to do is, Kathleen, do this. Kathleen is a marvel and did it automatically, so I am going to reinforce that behavior with a primary reinforcer. So a primary reinforcer is generally a food of liking, or a toy that the child only gets during this particular activity, okay? Because we want that to be really, really exciting. So we don't want it to be something like grapes, which the kid has every morning for breakfast, right? Because he's going to be like, that's not exciting enough. So generally it's something like Skittles or M&Ms. Now, I will tell you, where these programs are an hour to an hour and a half, right? So that's a lot of reinforcing that we're doing. I got really good and can split a Skittle into 8 different pieces.
Wow.
All right? I don't know how much my kids appreciated that, but I can do it. Now, eventually we want to fade away that primary reinforcer, right? Because none of us here in the real world get primary reinforcers every time we, quote unquote, do this. But it's a way to teach a specific skill. And so this time, Kathleen is not going to do it, all right? Spoiler alert, all right? So I'm going to say to Kathleen, do this, and I didn't get a response. Well, in ABA, no response is not okay. Because whenever we give a command, we always want to expect that the child is going to do it. So I'm going to use what's called a prompt to help Kathleen learn what I'm asking of her. So I'm going to say again, do this, and I'm going to take Kathleen's hands and help her clap, and then reinforce that. All right? Again, I'm going to be watching how much prompting that I'm doing. Because Kathleen is new to all of this, I'm going to be a little more forward with my prompting. I'm going to be very quick to reinforce that because I want her to pick up quickly what I am asking her to do. Now, kids on the spectrum, as we've already talked about, you know, are a wide range of symptoms and intelligence and things like that. So there are children who can pick up right away what I am asking them to do. There are other kids where I have to teach do this with 20 different activities because they have to learn each and every one, if that makes sense. Thank you very much, Kathleen. I appreciate it. I apologize, I don't have a Skittle to give you. Now, ABA has been criticized for that primary kind of reinforcer mentality, but what research tells us about kids on the spectrum is that they don't necessarily pick up things naturally from the environment. They're more externally motivated than intrinsically motivated. See if your notifications. Oh, it went away. All right. And again, we're working very hard to extinguish those primary reinforcers as quickly as possible. So by the end of a program, like by the end of teaching an activity like do this, I may be asking the child to do this 5 to 7 different times before I give him a primary reinforcer. So again, we're spreading that out. Also, once I know that the child can do this on a regular basis, we're going to put that particular task on maintenance, and I'm going to reserve that primary reinforcer for something a little more novel that the child hasn't particularly learned yet. Does that make sense? So again, ABA is very evidence-based because we're keeping records on everything that the child is doing. So whether the child did the trial independently, whether they required a prompt, and then what that prompt was. And that's how we know when the child has achieved mastery. So ABA is very intensive, it's a lot of paperwork, but it's highly effective. So that first kid that I worked with, again, who was diagnosed around 18 months or so and was doing such an intensive program, actually entered kindergarten with no diagnosis.
Wow.
Now, he was a little quirky, okay? But he functions, and in fact went all through school without any additional assistance and graduated and is now at OU. So, now ABA was not the only intervention that they used. They also did dietary therapies and supplemental therapies. He saw a chiropractor out in California, and if any of you are doing the math on how much this costs, it was very, very expensive. But again, the results were that he graduated high school, went all through school without a diagnosis, and is now at OU and doing very, very well. I want to show you ABA kind of in action with an actual child on the spectrum. So we're going to watch this, and I'll pause this video throughout and kind of talk about what you're seeing.
Hey Ryan, the new LG G7 Thank You can help you buy some sweet kicks. Cop some fire for your feet, babe.
The first video in the series will provide you with an overview of one of the basic tools used in intensive behavioral interventions, the Discrete Trial. The Discrete Trial is made up of several distinct components.
I think it's my bad. I was like, oh, I'll just turn down the volume. No.
No, it's kind of weird.
Is it?
Yeah, a little bit. I'll just get up here. You have to really turn it all the way up. And then you can manage it all here.
Oh, gotcha. You might want to close your ears.
It begins with the SD, or discriminative stimulus.
Do this.
Is that good? Can you guys hear me real quick? All right. Thank you.
This is the instruction given by the therapist to the child. Next, the therapist either waits for the child to respond or provides some help in the form of a prompt if needed. Finally, once the child has responded, the child is given reinforcement, a reward for a correct response or a correction for an incorrect response.
Let's try it again. Do this. All right, good trying. I like how hard you're working.
All right. So let's watch this again. It goes really fast.
You have just
Or not. All right.
The discrete trial is made up of several distinct components.
Nice sitting. Good girl.
It begins.
All right. So you notice that she's reinforcing everything this child does. So she says, "Come sit down," right? And that's an instruction. So anytime you give an instruction, you want to follow that up with a positive reinforcement. So she says, as soon as the child sits down, "Oh, that's good sitting." So again, following that up with a labeled praise so that child knows what we've asked of her and that she has complied. So again, this goes very, very quickly. Here she's using a Barbie doll as reinforcement. So this would be a doll that the child only gets during her discrete trial training.
With the SD, or discriminative stimulus.
Do this.
This is the instruction given.
You'll also notice that the reinforcer needs to be given very, very quickly because, again, we want to get through as many trials as possible. And so a lot of times when we're assessing what the primary reinforcer might be, parents will often say screen time, right? Well, it's not doable for us to watch a 30-minute Paw Patrol episode if we're doing discrete trial. And so we want to be very mindful about it being things that we can give and we can remove very, very quickly. Now, as the trials get more intense, more complex, they take longer, then the reward can take longer as well. So then we can employ, you know, screen time and things like that, although that's never my go-to reinforcer.
By the therapist to the child. Next, the therapist either waits for the child to respond or provides some help in the form of a prompt if needed. Finally, once the child has responded, the child is given reinforcement, a reward for a correct response, or a correction for an incorrect response.
Let's try it again. Do this.
So here we have the child being asked to do two different things, right? To do the little dance, but also to stand up. So the child does one of them, but doesn't do the other one. So that's still an incorrect response. So the coach here provides a little bit of physical prompt to get that child up and then reinforces. So these are all the things that you want to be mindful of when you're doing discrete trial training. Because if your only goal was for him to imitate, then you wouldn't want to pair that with standing up, because that's actually a two request, if that makes sense.
Oh, right. Good trying. I like how hard you're working.
You have just witnessed one discrete trial. After a brief pause, the therapist then begins another complete discrete trial. A discrete trial is made up of the following three components: an SD in the form of an instruction by the therapist to the child, a response from the child or a prompt from the therapist, and finally, reinforcement or correction if necessary from the therapist. Let's now examine each of these three components in detail, starting with the SD. Though generally an oral instruction, an SD can also be nonverbal, such as a picture, a toy like Mr. Potato Head placed on a table, or the sight of a swing.
You are super.
A good SD must follow several guidelines in order to be effective. First, all SDs should be clear and consistent. They should be free of extraneous information. And finally, they should be delivered in a voice slightly louder than a normal speaking tone. Now we will demonstrate what a good SD looks and sounds like.
Do this. Way to go! Wonderful! Touch half. Oh, wow! Oh, that sounds so neat! Doing match. Whoa!
Now we will demonstrate what a poor SD.
So again, we saw a couple different kinds of reinforcers being used. We saw lots of different skills being taught. So here we're teaching matching. One of the other activities was playing, and then we had an imitation. Questions? It's kind of straightforward. I like to show this because even though some of our families can't afford a full-on ABA program, there are things that you can incorporate from ABA into a typical family routine. So with any kid, we want to make sure that we're giving clear and consistent instructions, right? But this is especially true for kids on the spectrum. So maybe coaching the parent on what are they asking of the child and how are they asking it? And then making sure that we're using rewards that are appropriate, that the parent is giving labeled praise. That if it's a particular hard task that they're asking of the child, that we use maybe a primary reinforcer to help reinforce that. So again, although ABA might be outside of what a family can do, there are components of an ABA program that can be really helpful in teaching parents to manage behavior. Have any of you used ABA or heard of ABA or known families who have had an ABA program? Okay. Not surprising.
Let me ask you a question.
Yeah, please.
In this metro area, how easy would it be to access a program like that? Who does it?
There are several people who are trained. UCO, I believe, has an ABA program to teach therapists and to help therapists get certified. Laura, her first name is not Laura, Dr. Sweetdaughter, who's also out of UCO, and I don't believe has retired yet, used to run a clinic. I forget what the name was, but if you Google Sweetdaughter, you should be able to find it.
There can't be that many in the area.
No.
What name should be?
No, but it's more than there were, certainly. Yeah.
Is there an age range that works best for this, and like how long do they do it?
Early intervention tends to be most effective. We see it more like this for kids under the age of 5. But again, it can be used throughout childhood, even into adolescence, to teach different skills. Yeah?
How long does a session usually last? Because it seems very like enthusiastic and upbeat and probably really tiring.
It's exhausting. Typically my sessions were an hour and a half to 2 hours. So a typical day for the first child that I worked with that was in a really intensive program is I would do it from either 8:30 to 9 or 8:30 to 10 or 8 to 10. Then he would have about a 30 to 45 minute break, and then his mom would come in and do a session, and then he would have a grandma session in the afternoon after nap, and then I would come back in the evening from about 5 to 7 and do another 2 hours. So again, very, very intensive for his particular program. And Reaching Potentials would come in and teach us, again, every 4 to 6 months, but we would be videotaping sessions as well as sending our documentation to them to adjust the program. So every week we were adding new discrete trials that we were doing to, again, build on the skills that he already had. These are really good questions. Other questions? Awesome. So, as you guys know, I am a social worker. I am not a physician, but these are some of the medications that are often prescribed for kids on the spectrum. So you may come into contact with these in your work with this particular population. So, in infant mental health, a famous kind of child psychologist once said, "There's no such thing as baby," meaning that the children that we see for therapy or in our practices are attached to bigger people, right? Children don't grow up in vacuums. And so oftentimes, although the child who is on the spectrum is our client, there may be some work with the parent that we need to do. When I was doing therapy at a community mental health center here, I had a child who was referred to me who had just been diagnosed at age 5. Our first 8 weeks of sessions were just with mom to help her wrap her head around what this was going to mean for her family. I showed you pictures of Bo. If I didn't tell you he was on the spectrum, you probably wouldn't guess, right? Until you met him, and he's a little quirky and he has trouble making eye contact and he has some fidgets and he has a pretty distinctive stutter. But kids on the spectrum don't look like a kid with Downs or with cerebral palsy, right? They look like typically developing kids, and that can be really, really hard. I think the autism community is growing, and it's easier to find support and find other families who are dealing with it, but it still can be a very isolating situation. And so making sure that the families that you're coming to contact with have that support. Divorce is still very, very common in families where there's been a child with a diagnosis. Thinking also about siblings of the child. So the first child that I worked with had an older sibling. She was probably 2, maybe 3 years older. And it was really hard for her because I would come over and play with her younger brother, right? She didn't see it as work because we had toys and I brought food, and it was this kind of fun time in a 5-year-old's eyes, right? And I will never forget, one day I was kind of hanging out after session, and she comes up to me and she says, "Miss Amy, all I want is just a little brother, somebody who will play with me and spend time with me." And I'm like, "Babe, we're working on it. We're trying so hard." And so I would actually schedule some time to spend with her because it was very isolating that all of this attention was being spent on her brother. Fast forward, I'd been working with the family 2 to 3 years at this point, and I arrive at the house as I normally do, and I don't even think I knocked. I think she just opened the door as I was standing there, and I was like, "Sarah, what's going on?" And she looks like just kind of a mess, and she's probably 7 or 8 at this time. She goes, "Ugh, I have been dealing with him all morning, and he is into my stuff, and I was trying to play with a friend, and he came in and he ruined our dollhouse, and da-da-da." And I laughed. And she goes, "Why is that funny?" And I go, "Do you remember how 2 years ago you asked me for a little brother? This is what that looks like." And she was like, "That's not funny." But it's a very real thing, right? Because at first you have these kids who aren't interacting, and when I first met her brother, he was 18 months old, and he was sitting in a corner spinning and fidgeting and not making eye contact. And then 2 years later, he's playing and he's into everything and he's loud and rambunctious. And that's what we want, but that can be a hard thing for siblings, right? And parents as well. So really checking in on parents' sleep, social isolation, dietary needs, dividing time, and then that feeling of grief. Bo's family, because I've been involved with them for 16, 17 years at this point, I've seen them at their highest and at their lowest. And I'll never forget, Bo was in 1st grade and they were having a field day at school, right? Everybody loves field day, except for your kids on the spectrum, right? Because they're at school, but their schedule is a mess, and there are all of these fun activities, but it's really hard for kids on the spectrum to adjust. And his mom had come in to help with the activity, as parents do, right? To help with field day. And she finds Bo hiding underneath his desk. And all these kids are having all of this fun except for her kid. And that was really hard. It's different when we're at home and it's just him and there's not this direct comparison. And so those feelings of grief come up. Bo is actually doing really, really well. He's at the Non-Pareil Institute. He's participating in this program where they're using AR technology, so virtual reality, to teach kids how to conduct themselves in social interactions. So for instance, one of the simulations is a movie theater. So walking them through how to go in, buy a ticket, get popcorn, sit down for the movie, and then leave again. And again, all the social things that can go wrong, we can control in this alternate reality, and then prepare them for going out and doing this in the real world. So, I mean, that's incredible. He's living with his grandparents. If you subscribe to his YouTube channel, every Monday morning he posts carpool karaoke with his grandpa. I got to guest star a couple weeks ago. It was fantastic. Where we did a rendition of Beer Run. And so, I mean, Bo has an incredible life, but he's 20. His dad had a really hard time that when he graduated high school that he wasn't going and pledging. I don't think it's not pledging a fraternity. Is it pledging a fraternity? All right, thank you for the correction on the language. I didn't do those kinds of things. You know, he didn't live in a frat house. He didn't go to a typical university like OU or OSU, like their friends' kids are. And so that's a different amount. It's a different kind of grief. And again, they're very thankful. I was talking to his parents a couple years ago, and they had taken their nephew, who's several years younger than Bo, to the zoo or something like that, and they were like, he talked the entire time, which is different because Bo talks, but like it's not chatter, right? It's not that like kind of incessant small talk that 8-year-olds tend to do. Like, why is the sky blue? I think the sky is blue because of the ocean. And do you know what lives in the ocean? And Bo is not like that at all. And so they came home and they were just like, oh my gosh. So it's just different. And so being mindful that our families who have a child on the spectrum are going to go through those different feelings of grief, and then also happiness when, you know, milestones are met that they didn't necessarily think possible. When we are seeing children in our offices, we want to use person-first language, so children with ASD, not autistic persons. So making sure we're putting that family or that child first before we give them the diagnosis. We've talked about their sensory needs, so having things like finger fidgets in your office, being mindful of lighting in your offices and sound and things like that. So, you know, if you have a clinic room that's maybe more isolated, a little bit quieter, that might be a better situation than maybe one that's out in the middle of everything. Children with ASD are concrete thinkers. We need to be very careful with our language. This is really with all kids. I had a kid who's not on the spectrum whatsoever, and I was watching him for one of my friends, and he was probably 4 or 5 at the time, and I was really excited because I was going to spend the night with him because his parents were going to a reunion and they were spending the night in a hotel, and we were going to make a craft and eat pizza and watch movies, and then the next morning we were going to go to the park, and I was really looking forward to this. And I got to his house and he was a nightmare. He was hitting, at one point, like I was watching, he had a fish tank in his room and I was looking at his fish, and the kid comes up to me and says, "Are you looking at my fish?" And I said, "Yeah." And he goes, "He doesn't like you." And I was like, and I couldn't figure it out because I met this kid before and we had gotten along great and I was really looking forward to this. I put him in bed by 8. I let him sleep until 11 because I didn't want to deal. No, not really, because kids wake up at the butt crack of dawn, I learned. But I mean, I was just like, I can't figure this out. I'm usually very, very good with kids. This is very unlike him. His mom calls me several hours later and says, "I think I messed up." And I was like, "What happened?" And she goes, "Well, yesterday we were talking about you coming to visit. And I explained to Aiden that you were going to be kicking mommy and daddy out of the house and going to be spending the night with him." And Aiden took that literally to mean that I had physically assaulted his parents. and removed them from the home and was going to force him to have fun, and he was having none of it. We very quickly explained to him that that is not what happened, and that kicking is a figure of speech. But we run into this all the time with kids, and especially with kids on the spectrum. So for instance, if you say it's going to be a piece of cake, you better have that piece of cake ready to give to that child. So things like that. And of course, just being patient and kind, as we are with all of our families. Some Oklahoma resources. There are federally funded programs across the nation, but the one here in Oklahoma is Sooner Start for kids under the age of 3 for this type of early detection and early intervention. Now, because of funding, even at the federal level, services are getting harder and harder to qualify for early intervention services from Sooner Start. You have to be 25% deficient in 2 domains or 50% deficient in 1 domain. So kids on the spectrum are typically going to have that, but a family may need help documenting that to make sure that they get those services. For children over the age of 3, the liability falls to the Department of Education. I have often seen, and I'm hoping that this gets better, that those 3-year-olds kind of get caught because they're too old for Sooner Start, but the Department of Ed sometimes drags their feet to pick them up. So if you have kids that are at that 3-year-old range who have been receiving early intervention services, you may just want to put a bug in mom or dad or caregiver's ear to say, hey, you do have a right to services through the Department of Education. There's also the Oklahoma Autism Center, which is housed at the OU Health Science Center, and then there's the Tulsa Center for Autism as well. There's some national organizations as well, such as Autism Speaks, as well as CHAD. That can be very, very helpful. I've talked about the CDC. That is a great place to get handouts for parents. Again, some of those screening tools are available on the CDC website, as well as just some general information about helping families who are affected by this disorder. I want to thank you guys so much for having me, and Kathleen for being my